Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Treatment of High-Risk Philadelphia Chromosome-Negative Acute Lymphoblastic Leukemia in Adolescents and Adults according to early cytological response and minimal residual disease after consolidation assessed by flow cytometry. Final results of PETEMA ALL HR03 by Josep Maria Ribera et al. My name is Renato Bassan, and I am the director of the hematology unit at Venice General Hospitals, Italy. My oncologic specialty is hematology. Let me start illustrating the clinical setting of this study to better understand its value and implications for the management of adult ALL, a disease that exhibits an ample biologic and clinical prognostic heterogeneity. Proper management requires a detailed immunophenotypic, cytogenetic, and genetic evaluation in order to obtain a correct risk stratification, which is necessary to make critical treatment decisions, like offering or not an allogeneic stem cell transplantation to a patient who is in complete remission following induction and consolidation therapy. Now, this is crucial in the context of modern risk-oriented therapy, because although transplantation is more effective than chemotherapy in preventing relapse, it is also more toxic, causing non-relapse mortality ranging from 15 to 30%. There are several prognostic factors that may guide clinicians in this decision, but patients with high-risk ALL are normally considered for transplantation. High-risk ALL is usually defined by an age greater than 35 to 50 years, a white cell count exceeding 30 or 100,000 per microliter in B and T precursor ALL, respectively, by some adverse cytogenetic, genetic, and immunological characteristics, and by a poor response kinetics. The latter is becoming more and more relevant, especially in the form of minimal residual disease analysis, referred to as MRD in this podcast. In fact, MRD appears to be superseding the majority of traditional risk factors in this disease. Response kinetics is available in different ways. The simplest is looking at the bone marrow midway through induction therapy in order to assess early disappearance of blast cells. The more sophisticated method is to perform a serial MRD analysis during induction consolidation cycles by either flow cytometry, like in the study, or molecular biology to detect residual leukemic cells with a sensitivity of 1 in 10,000 with flow cytometry to 1 in 100,000 with molecular biology. Now, this information can be extremely useful because MRD-responsive patients, who are those reaching below this threshold, could be spared the toxicity associated with allogeneic transplantation, as already suggested by some trials in both adults and children. However, in adult ALL, at least 40% of all patients express one or more clinical high-risk feature. And while it is easier or generally more agreeable to consider an MRD-guided transplantation policy in standard-risk patients, this issue is still debated in the high-risk category. The paper by Rivera et al. Partially fills in this gap. In this prospective clinical trial, enrolling more than 300 total patients with high-risk AML and an age range of 15 to 60 years, The patients in first complete remission were shifted to allogeneic stem cell transplantation on the sole basis of a poor response kinetics, regardless of the clinical risk class. This was defined by more than 10% residual blast cells in the bone marrow evaluated on day 14 of induction, or by a positive flow cytometry MRD study performed at the end of consolidation, with MRD levels above 5 times 10 to the minus 4. All the patients with good early blast cell clearance and MRD response were instead scheduled to receive chemotherapy only. With a good number of available patients at the end of early consolidation and MRD study, that is 76% of all remitters, and an extended follow-up, the authors were able to conclude that, first, MRD was the most significant prognostic factor for relapse and hence survival and disease-free survival in multivariable analysis. Second, the allocation to chemotherapy of high-risk patients with a negative MRD study, 60% of the total, was a rather successful choice, resulting in a survival probability close to 60%, which is remarkable in view of their clinical high-risk profile. Third, the allocation to allogeneic stem cell transplant of patients with a positive MRD study was only partially successful due to a rather high relapse rate, 45%, which together with transplant-related mortality led to an overall survival of less than 30%. Apart from some weakness of the MRD study related to the use of flow cytometry instead of molecular analysis, which is 1 log more sensitive and better standardized, I believe this is an important clinical study, directly addressing the question of whether high-risk ALL patients who are MRD negative can be treated with chemotherapy only, with the expectation of obtaining a satisfactory cure rate, avoiding the relatively high risk of no-relapse mortality from transplantation. The answer to this question seems a positive one. What the study does not show is whether the same patients could fare even better with transplantation, but the study was not designed for that, and no one can say it unless high-risk MRD-negative patients are randomized to either chemotherapy or transplant, which is unlikely to occur because exposing MRD-negative patients to transplant-related mortality may not be acceptable. But what the study also shows is that many MRD-positive patients do not fare well with transplantation because of both high relapse rate and non-relapse mortality. In summary, thanks to these and other similar studies, it is about time to have MRD analysis integrated into modern treatment platforms, with or without transplantation, for any risk subset of adult ALL. Only efforts of this type can overcome the barriers of the long-lasting chemotherapy versus transplantation debate, trying to identify which therapy is best suited to address the needs of individual patients and specific clinical prognostic conditions. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.